now come to the question part.
So next will be the symposium. This will be given by Dr. Talal Al Taweel, who's a consultant gastroenterologist and head of Jabal Ahmed GI Center. Dr. Talal.
Bismillah wa salatu salam ala Rasulullah. Assalamu alaikum and good morning or good afternoon, everyone. I'd like to thank Muhammad for the introduction and the KJA for the invitation, and Hikma for sponsoring this symposium. So I'm going to do a whirlwind presentation because I think we're late and people want to run away for the Friday prayers. So the topic has been assigned to me is to talk about the unmet needs in acid suppressions. So this is Hikma's disclaimer. And these are my disclosures. So what I'm going to do is just do a quick, very rapid sort of overview of GERD, just because we have a mixed audience of gastroenterologists, primary care, internal medicine, just about how to diagnose and a bit of the complications, how we assess GERD and the pharmacologic and non-pharmacologic management, and then we'll talk about obviously Dexalant after that, and then hopefully just summarize with a few take-home messages. So the definition of GERD has actually evolved over the last 2 decades or so. So this is for example, from the 1999, it was a very sort of vague definition. As you can see, it says all individuals exposed to the risk of physical complications from reflux. This is from the GenVal workshop report. Who experience clinically significant impairment of a health-related well-being due to reflux-related symptoms. So sort of like a very vague sort of general definition to a more focused and more objective definition, I think, if you compare it to more recent guidelines in the ACG in 2021, where it was very objective. So the definition, there's actually an objective finding there. So the condition is where there's reflux of gastric contents into the esophagus that results in symptoms or complications. And GERD is objectively defined by either finding erosive esophagitis on endoscopy, so finding mucosal injury, or having an abnormal pH study. So it's really objective definition. I think that's the way we should be defining GERD now. And we know that, I won't spend too long, but the pathophysiology of GERD is really due to a poorly functioning esophagogastric junction, which is the anti-reflux barrier, which is composed of obviously the LES and the crural diaphragm. And what happens is that the reflux of the gastric juice into the esophagus causes the damage to the esophagus and the sensation of heartburn or regurgitation. Obviously, there are other factors that are involved, such as decreased salivary production, gastric emptying, and esophageal hypersensitivity. And really, the prevalence is underestimated. So most of the patients actually don't come to see the physicians. A lot of them just go use over-the-counter antacids. Some of them consult a pharmacist. Because we have PPIs here over the counter as well. I think it is the same in other countries. And only 50% of our patients actually reach a physician. So a lot of them wait a very long time before presenting to a healthcare professional even. And it's important really to define the meaning of the symptoms that the patient complain of. So we know what they mean, and when we communicate to each other, we know what each symptoms mean. So heartburn is the burning sensation that you get from the epigastrium rising up to the neck. So that's what's heartburn, right? So it's the sort of the painful heart sensation here. Regurgitation is the effortless return of the gastric juice, whether it can reach up to the throat, so they get a sour taste in the throat or in the mouth, or sometimes it might even come out. So it's important to differentiate when you're those two symptoms, when you're communicating with healthcare professionals or when you're asking the patient for the symptoms. Chest pain, which can be also a symptom of GERD, it can be very similar to cardiac pain, and if the patient does have cardiac risk factors, they might need a cardiac evaluation. And there are also extraesophageal manifestations that we'll touch upon later. So I actually like the algorithm from the ACG about the way to sort of diagnose GERD. So if the patient presents with one of those symptoms that we mentioned, then you give them an 8-week trial of standard dose PPI once daily. So you don't start with the BID with high dose, start with the standard dose PPI once daily. If they pay for 8 weeks, and the duration usually is 8 weeks, because most of the studies show that you need 8 weeks to heal the GERD. If they do well and good, you down prescribe the PPI. If they recur, then you do need to refer them to a gastroenterologist for an EGD. If you do an EGD and the patient has erosive esophagitis B or above, that actually diagnoses GERD. A doesn't, right? There's a lot of inter-observer differences been noted with LA classification of Class A erosive esophagitis. If the patient has a normal EGD, then you need to still prove an objective evidence of reflux of PPI with a pH study. So I like the algorithm, very simple and easy to follow. So there are two main categories of GERD. So we've got erosive esophagitis basically, and non-erosive reflux disease. And out of the erosive esophagitis, you have the erosive esophagitis and the complicated reflux disease. And why do we worry about reflux? I think Dr. Wadha mentioned one of the main sort of complications in her Barrett, very nicely in her Barrett esophagus lecture. Well, we got reflux esophagitis can lead to peptic strictures and can lead to Barrett's esophagus, which obviously can lead to the dreaded complication of esophageal adenocarcinoma. So I just wanted to maybe tell our non-gastroenterology colleagues about how we classify erosive esophagitis, because you get these reports from us as internists or as primary care. So I just wanted to know what we're talking about when we mention that. So we classify erosive esophagitis on a grading system. There's many, but the most commonly used is the LA classification, which is A to D, and that depends on the length of the mucosal break, the severity of the mucosal break in the GE junction. So A is the mildest form, while D is the most severe. So when you read the report, as we're going down the letters to D, it means that there is a more severe esophagitis. So are there non-pharmacologic measures for GERD? Yes, there are. I think we should always mention to the patient it's a combination of pharmacologic and non-pharmacologic management. So weight loss is important to mitigate the symptoms of GERD, because that does increase the risk of GERD. And the postulated theory how that does is the diet and high fat can promote reflux, and as well as the increased intra-abdominal pressure can also make the symptoms worse. You try to tell the patient to avoid meals within 2-3 hours of bedtime to promote gastric emptying, so the stomach is empty when they lie down. To avoid tobacco products and smoking, because that's been shown to decrease LES pressure. And then to avoid trigger foods for GERD symptoms. So there are some foods that actually don't have an effect on the LES pressure, but in someone with pre-existing GERD, they can trigger their symptoms, such as coffee, caffeine, citrus, and spicy foods. So they're irritants, but they don't actually have an effect on LES pressure, while there are other foods actually can also affect LES pressure, such as alcohol, tobacco, chocolate, peppermint, and high-fat foods. They can actually reduce the LES pressure in vitro, so just to know what things to sort of avoid. And elevation of the head at nighttime can also help the patient to alleviate their nocturnal symptoms, if that's what they're complaining of. So I think I just wanted to show everyone the FDA-approved doses of the PPIs, right? Because a lot of us use super high doses unnecessarily, and I think it's important to know that we don't a lot of the time need these very high doses. So these are the FDA-approved doses of the drugs for, I'm speaking about erosive esophagitis and non-erosive. So this is GERD. We're not speaking about dyspepsia or Helicobacter. So for Dexilant, it's 60 milligram for healing initially, and then maintenance is 30. For esomeprazole is 20 to 40. Lansoprazole is 30. This is induction. Omeprazole 20, pantoprazole 40, and rabeprazole 20. So you can see I'm an IBD specialist because I'm using induction and maintenance. So with maintenance, so once you heal this patient, you want to really step down to the lowest effective dose. So these patients shouldn't stay on this super high dose for long. You want to go down to the maintenance dose, which is usually the lower. In Dexilant is 30, and then as you can see, this is the other doses. And for non-erosive GERD, usually it is the lower dose that you would start with and not the high dose. So what do you do in your patients with GERD? So when the patient, whether has erosive esophagitis or non-erosive, you would start your PPI once daily for 8 weeks. Once the symptoms are controlled in non-erosive reflux, you would want to actually down-prescribe your PPI up to the lowest effective dose, or even do like a pill-in-the-pocket kind of management where the patient would take the PPI as needed. However, with sort of grade C or D, more moderate to severe GERD, data has shown that these patients tend to recur when you stop, and most of them do need long-term maintenance therapy with the lowest effective dose of PPI. Just to touch on extraesophageal GERD symptoms, so there's a lot of associations, but the ones with the strong association is reflux, cough, laryngitis, asthma, and dental erosions. You need a detailed medical history to identify, obviously, the other potential causes. It's usually with patients that present like this do need consultation from multiple specialties to make sure that there's no other underlying cause other than GERD. You would only really start in these patients a PPI if they actually have heartburn symptoms. If they don't have reflux symptoms, it's not advised to start a PPI, and actually you should check objectively for GERD with a pH study. It's very important not to start these patients on a PPI because patients can get, anyone can get better with PPI, but doesn't diagnose GERD for you. So if they have an extraesophageal manifestation with reflux symptoms, you start a PPI, and it's usually the higher dose BID. If they don't, then you actually want to do a pH study to confirm, to rule out GERD. So we'll move on to sort of the next sort of, that was just a quick overview of reflux, just to speak about sort of the unmet needs with current PPIs. So there's a suboptimal symptom control with around a third of our patients on once daily PPI say that therapy fails to provide their complete symptom relief, and up to half of the patients on once daily PPI supplement it with other medication, whether they go to twice daily or they would add another agent, either an antacid or H2 receptor antagonist as well. However, with the twice daily, you know that adherence is more difficult for these patients to adhere to a twice daily therapy compared to once daily. And as you can see here, a lot of the breakthrough symptoms that the patients get with once daily PPI is usually nighttime, which is the disturbed sleep at night, which can be really bothersome for the patients, and only around 23% of our patients on PPI have complete satisfaction. And just remember that our PPIs only inhibit the active proton pumps, so they're active. Remember, before a meal, if you don't take them before a meal, you don't block all the pumps. The other things, these pumps are continually regenerated, so you get new pumps that appear. So then these are not blocked. And remember, the problem with PPIs is a very short half-life. Most of them are around 1 to 2 hours. So then the patients, you'll notice that they'll start recurrence of symptoms very short after the initial relief. As you can see, the PPI blocks the activated proton pumps, and then after a few hours, it drops below the effective plasma level when they're taking once daily dosing, and then you're in need of a second dose to boost that sort of evening effect. And we spoke about the short half-life, so as you can see with the conventional PPIs, you have that big peak initially, just as you see, just after breakfast, and then rapidly as we're reaching sort of lunch or dinner time, you can see that already falls below the therapeutic sort of level, and only 25% remain 4 hours post-dose, so only 5% remain 8 hours post-dose. So we spoke about that they have to be taken before meals, and the recommendation is for optimal use is to take them 30-60 minutes before meal. This is actually a very nice study that I came across, just the common question by our patients, where they actually take they ask you, I take my PPI in the morning, but I don't take a meal, is that all right? So I don't eat anything until lunch. Do I have to eat anything? I'm not a breakfast guy, so I just have my PPI and go. So does that work? So actually that was looked at. It's a very small study, but they randomized patients to omeprazole or lansoprazole in the morning, either 15 minutes before a breakfast meal, without food, or with food. And what they found is that there was a significant improvement if you take it after even a small meal in the morning. So if you get that question, we would advise the patient, even if they're not a breakfast person, maybe to take a small meal just before, because that does increase the efficacy of your PPI. So in summary, what's sort of the limitations of the current PPIs? The short half-life we spoke about, cannot control the acid secretion over a 24-hour period with a single dose. You have the nocturnal acid breakthrough that leads to nocturnal symptoms, and you require the meal-associated administration. And a problem that's maybe particular to our region is Ramadan, that you guys aren't exposed to in the West. So you're starving all day, and then it comes to futur time at sunset. Everyone is eating. You've got this, as you can see, this table of delicacies in front of you, and then you can't have your food because you have to wait another half an hour before you can eat anything when everyone has finished their food by that time. So it's very challenging in Ramadan, and then you have the other issue is nighttime, right? So then we have a second meal very late at night, and then you can't You can't have any medicines though, because you have to hold your fast, start your fast around at sunrise, right? So then you get the reflux symptoms bothersome after that. So it's a very unique problem for our region, and that's when we're speaking about when sort of Dexilant came into it. We'll see how that sort of works. So we'll speak about Dexilant in the next couple of slides. So it was approved in 2009. It has a dual delayed release formulation designed to prolong the suppression of the gastric acid, and combines two types of enteric-coated granules, each one with a pH-dependent release to extend the drug delivery. So the way it works, you get two granules, so 25% released at a pH of 5.5 in the duodenum within 1 to 2 hours, but the majority of the release is actually later on in the small bowel, which is comprises 75% of the actual active ingredient. And if you see it here, this is Dexilant. You can see the mean sort of concentration. As you can see, you get the first peak, and then you get the second peak. Oh, the pointer doesn't work. So you get the second peak after 4 hours. You can see a much longer duration of the active ingredient compared to other PPI. This is Dexilant beside lansoprazole, and you can see the second peak. Although there is a higher peak for lansoprazole initially, you get a second peak with Dexilant that maintains a longer duration of the active drug concentration. And this is also Dexilant compared to esomeprazole. So very effective, obviously, esomeprazole initially, you get a very high peak, but then you get the same trend as with all conventional PPI. This is taken, obviously, esomeprazole once daily, remember, not twice daily. And you can see the intragastric pH, whether you take the Dexilant before lunch, before breakfast, dinner, evening snack, there's no variation. So you can see that it maintains the level above the active ingredient at whatever time. So it's not really affected at time of administration in terms of the acid suppression. So it can be taken, as I said, without regard to food, and we know PPIs can lose up to 70% the bioavailability when taken with food. And we showed that there's no difference in the intragastric pH, whether it's taken before food or at different times of the day. So in summary, we said the dual release technology provides the initial at 1 to 2 hours, the second release after 4 to 5 hours, and allows administration at any time. Just the last couple of slides, we'll go through the clinical program for Dexilant. So there were 2 large studies looking at erosive esophagitis and non-erosive disease, over 4,000 patients. They were randomized in the erosive to 30, 60, or 90 of Dexilant, and the non-erosive was actually randomized to 30 and 60 in the induction arm, which is 8 weeks, and then the maintenance, you step down to the lower doses, and they were re-randomized to either placebo or Dexilant. And as you can see here, although initially they were equivalent to lansoprazole, at week 8 you can see there's superior healing in patients that were in Dexilant compared to lansoprazole. And out of this cohort, you can see a lot of them, around 30%, had that difficult to treat CD erosive esophagitis, so out of sort of like a refractory population that are more challenging to treat. And I think that's where it shows, if you look at the group, in that particular group, you can see there's a significant delta there between lansoprazole and Dexilant and this difficult to treat group compared to lansoprazole. And then in terms of so this is the maintenance study. You can see they were re-randomized to placebo, Dexilant 30 or Dexilant 60 in 2 parallel arms. And you can see the superiority of both the Dexilant 60 and Dexilant 30 compared to placebo. And what it shows is significant, we spoke about the nocturnal breakthrough symptoms. There is a significant reduction of the nighttime breakthrough symptoms in patients on Dexilant compared to placebo. So the safety, it's been tested in over 5,000 patients in their clinical trials, and there were no safety signals there. It's a pregnancy category B, no effect in QT intervals as well. So the label for it, remember, so it's labeled for healing of erosive esophagitis, as well as maintenance of healed erosive esophagitis, as well as symptomatic non-erosive GERD. It comes in 30 and 60 milligram capsules. You can take without regard to food. No real dose adjustment is needed for renal or mild hepatic impairment. My last slide, really, I actually copy-pasted this from the ACG guide. I actually like this. It's something you can tell your patients. about this concern with PPI. So actually, I used it since I've read it. I actually liked it. Just sort of a layman's explanation of the safety of PPI. So I'll just read it actually because it's really a nice way of explaining it. So we say PPIs are the most effective medication you tell your patients, because we get that question a lot about safety. They're the most effective medications for GERD. We know that there are some studies that showed an association between PPI safety and adverse events. However, better quality studies only showed there is a high risk of enteric infections, right, in the higher quality. And they cannot establish a cause and treat. And so what I tell the patients is that you cannot exclude the possibility that PPIs might confer a small increase in risk. However, with our current best data, they don't confer a high risk. However, the most important thing is that you take your PPI if you need it. And that's, I think, the most important thing. So my last slide is take-home messages. GERD is obviously a very important disease. It's seen by multiple specialties from primary care to gastroenterologists. Non-pharmacologic as well as pharmacologic means are just as important. PPIs are obviously your backbone for GERD management. And I think we all have to be familiar with their dosing and with their durations in management of GERD, and know the indications on when, or your alarm signs, and when you need to refer to a specialist. Thank you very much.